You don't feel your fingers dying. There's no alarm, no sharp pain that tells you to stop. No moment where your body says, "This is serious, pay attention, something is wrong." 1 minute, your hands are cold. And then, before you've processed what's happening, the process has already started. The cells in your fingertips have already begun to change in a way that cannot be undone. The tissue that was alive 10 minutes ago is moving towards something that surgeons have a clinical word for: necrosis. Dead tissue. And you felt nothing. This is what -40 degrees Celsius does to your body before you even notice it's happening. Not the dramatic version, not the version from movies where someone collapses in the snow. The real version. The one that plays out silently, invisibly, in the skin and tissue of your fingers while you're still standing, still moving, still thinking you're fine. And the reason it matters isn't just mountains. The mechanism that kills fingers at -40 degrees is the same mechanism that has taken limbs from soldiers, from homeless people caught in winter storms, from children who stayed outside too long. It doesn't care who you are. It doesn't care how fit you are or how much your expedition cost. It cares about one thing: temperature and time. Stay with me, because once you understand exactly what happens inside your tissue in those first 10 minutes, you will never think about cold the same way again. If you're new here, this channel goes deeper than the headlines. Subscribe before you keep watching so you don't miss what's coming next. It takes 2 seconds. Let's get into it. Let's start with the first thing your body does when it detects cold. The moment temperature receptors in your skin register a serious drop, they send a signal to your hypothalamus, the part of your brain that manages temperature regulation. The hypothalamus responds within seconds with a single priority command: protect the core. Not the hands, not the feet, not the ears. The core. The heart, the lungs, the brain. These organs require a stable temperature to function. If they cool down, you die. If your fingers cool down, in the brutal calculus of your own biology, that's an acceptable loss. So your body begins vasoconstriction. The blood vessels in your extremities, your fingers, your toes, your ears, your nose, begin to narrow. The blood that was flowing through them starts to retreat toward your torso. Your core temperature is maintained. Your fingers are sacrificed. This is not a malfunction. This is your body working exactly as designed. But here's what makes -40 degrees different from regular cold. At normal winter temperatures, -5, -10, vasoconstrictions, the cooling of your fingers. Your core stays warm. Some blood still reaches the periphery. And if you go inside within a reasonable time, everything is fine. The system works. At -40 degrees, especially with wind, the system is overwhelmed. The heat loss from exposed skin at that temperature is so rapid that vasoconstriction alone cannot keep pace. The blood retreats. The fingers cool anyway, and they cool fast. Hit the like button if you want more of this. It tells YouTube to show this to people who've never heard any of it. 1 click. Now let's get into what actually happens to the tissue. In the first minute, what you feel is cold, burning, sometimes a deep ache. Your fingers are uncomfortable, and your instinct is to pull them into your palms or put your hands in your pockets. This discomfort is actually good news. It means your nerve fibers are still transmitting signals. The pain receptors in your skin are doing their job, sending warning signals up through your nervous system to your brain. Your body is communicating clearly. But here's what's happening underneath the sensation. Myelin, the protective sheath around your nerve fibers, begins to conduct signals merely as temperature drops. Every degree of coolens the transmission. The signal weakens. The ache begins to dull. By the second or third minute at -40 degrees, something shifts. The burning starts to fade. And most people, when the burning fades, feel a sense of relief. The worst seems to be passing. Their hands are still cold, but the sharp pain is gone. They feel like they can manage it. This is the trap. The pain isn't fading because the danger is passing. The pain is fading because the nerve fibers have cooled to the point where they can no longer carry the signal reliably. Your body has lost the ability to warn you. The alarm system has gone offline. And this is the exact moment when the real damage begins to accelerate. Because while you're standing there thinking the worst is over, the temperature in your fingertips is still dropping. The cells in your skin are still cooling. And at a precise point, 0 degrees Celsius inside the tissue, something begins that cannot be reversed by simply warming back up. Water in the spaces between your cells starts to freeze. Not inside the cells yet, in the fluids surrounding them. These ice crystals form and grow. And as they grow, they do two things simultaneously. First, they create physical pressure against the cell membranes, mechanical pressure from ice crystals pushing against the walls of living cells. Second, they pull water out of the cells through osmosis. The ice outside the cells has a lower water concentration than the fluid inside the cells, so water moves outward. The cells shrink. They dehydrate from the inside. This process is called extracellular ice formation, and it is the beginning of frostbite. Surgeons and researchers who study cold injury describe what happens next as a cascade, one event triggering the next, each one making the next more likely and more severe. The cells shrink. Their membranes are stressed by dehydration and mechanical pressure from ice crystals. Some membranes begin to fail. When a cell membrane fails, the contents of the cell leak out into the surrounding tissue. The cell dies. But not all cells die at once. The process moves in a gradient, from the surface inward, from the coldest areas to the warmer areas deeper in the tissue. The skin surface cools fastest. The deeper tissue takes longer. This gradient is also why frostbite is so visually deceptive. From the outside, the skin might look pale, waxy, intact. No open wound, no obvious damage. The tissue underneath is dying, and the skin looks almost normal. The full visual evidence, the blisters, the blackening, the necrosis, comes later, when the tissue thaws and the true extent of what happened is revealed. Climbers who've lost fingers describe in interviews a consistent sequence. They remember the pain, then the numbness, then a strange sense of calm. They remember thinking their hands looked fine. They remember continuing with whatever they were doing, photographing the summit, adjusting equipment, checking coordinates, for minutes after the numbness set in. They had no idea. Subscribe if you haven't yet. This channel is Something, a series that goes into the real biology of what happens to the human body at its absolute limits. Not the inspirational version, the real version. Subscribe so YouTube actually shows it to you. Button is right there. Let's talk about what wind does to this entire equation. Because on a mountain above 8,000 meters, wind is almost never absent. Wind chill is not a perception phenomenon. It is a physical reality. Wind accelerates the rate at which heat is removed from a surface. Still air near your skin acts as a minor insulating layer. Your own body heat warms it slightly. Wind strips that layer away continuously, constantly exposing your skin to the full cold of the ambient temperature. At minus 40 degrees Celsius, with a wind speed of 15 meters per second, which is not unusual on a high-altitude summit. The effective temperature your skin experiences is equivalent to approximately minus 66 degrees Celsius. Minus 66 degrees. At that effective temperature, researchers studying cold injury have documented irreversible frostbite beginning in under 2 minutes of exposure on bare skin. 2 minutes. This is not a worst-case scenario calculation. This is what the physics produces. Now add what a mountain does to your body before you even get to the summit. At 8,000 meters, The partial pressure of oxygen in the air is roughly 1/3 of what it is at sea level. Your blood oxygen saturation, which should sit between 95 and 100% normally, drops to levels that in a hospital would trigger emergency intervention. Some climbers measure in the 50s and 60s on their pulse oximeters near the summit. Hypoxia, oxygen deprivation, causes your blood to thicken as your body produces more red blood cells to compensate. Thicker blood flows morely. Blood that flows morely transfers heat less efficiently. Tissue that receives less blood flow cools faster. And you are already dehydrated. At high altitude, your respiratory rate increases dramatically, 3 to 4 times faster than at sea level. Every exhaled breath carries moisture. Over a 12-hour summit push, a climber can lose 2 to 4 liters of fluid through breathing alone. Dehydration makes blood even more viscous, evener, even less able to deliver heat and oxygen to the extremities. By the time a climber reaches the summit and stops to take photographs, which might mean removing a glove to operate a camera or adjust a device, their body is already at the absolute limit of its ability to protect peripheral tissue. The margin is gone before they take the glove off. Okay, pause here and answer this for me in the comments. Knowing everything I just told you, if you were on that summit, hands already compromised, glove in your hand, camera ready, do you think you'd put the glove back on before taking the photo? Or would you tell yourself it's just 30 seconds? Drop your answer below. I read every single comment, and I genuinely want to know. Let's talk about what happens between minutes 5 and 10. The ice crystals in the extracellular fluid are still growing. As more water is drawn out of the cells and joins the ice structure outside them, the crystals increase in size. Larger crystals create more mechanical pressure. More membranes fail. More cells die. But simultaneously, something else is happening in the blood vessels. The damage to surrounding tissue triggers an inflammatory response. Even in the cold, even at reduced metabolic rate, the body is trying to respond to injury. Inflammatory mediators are released. These cause increased permeability in the walls of blood vessels. The vessels become leakier. Fluid moves out of the vessels into the surrounding tissue. Simultaneously, the blood that remains in the small vessels of the fingers has become extremely viscous from cold and dehydration. It begins to sludge. To move solely, it nearly stops. And then, in the smallest capillaries, it stops entirely. Small clots, microthrombi, begin to form. These microthrombi are physically blocking blood flow in vessels that are otherwise structurally intact. The vessel isn't broken, the vessel isn't destroyed, but nothing is moving through it. The tissue it supplies receives no oxygen, no nutrients, no heat. The tissue beyond the clot dies not from freezing alone, but from ischemia, from being cut off from its blood supply even as the rest of the circulatory system continues to function. This is the mechanism that modern frostbite treatment targets most aggressively, because microthrombi can be dissolved. In the last 2 decades, the treatment of severe frostbite has been transformed by thrombolytic therapy. Drugs that dissolve blood clots, delivered either intravenously or directly into the arteries of the affected limb. Clinical studies have shown that when thrombolytic therapy is administered within 6 hours of tissue rewarming, a significant portion of tissue that would otherwise require amputation can be saved. Fingers that would be gone, preserved. But the window is 6 hours from rewarming, not from injury, from rewarming, which means the climber still has to get down the mountain, has to get to a facility capable of delivering this treatment, has to get there within a timeline that the mountain, and their own compromised decision-making, makes incredibly difficult to meet. And this brings us to the most disturbing part of the entire picture. The brain at altitude doesn't work the way the brain at sea level works. Studies conducted on subjects exposed to simulated high-altitude conditions, low oxygen environments in laboratory settings, have consistently shown the same pattern of cognitive impairment. Executive function degrades. Risk assessment becomes unreliable. The subject's perception of their own impairment is itself impaired. In plain terms, you don't know that you're thinking worse than usual. You feel sharp. You feel capable. You feel like you're assessing the situation clearly. You are not. Climbers in documented incidents, cases where there are radio logs, written records, testimony from teammates, describe making decisions in the death zone that they cannot explain when they review them from sea level. Decisions to wait. Decisions to continue. Decisions to delay descent for reasons that seemed completely logical at the time and make no sense afterward. The glove that came off for 30 seconds and stayed off for 4 minutes. The hand that was white and numb but felt manageable enough to keep moving. The summit that was close enough to justify pushing past the turnaround time. Every one of these decisions was made by a brain running on a fraction of the oxygen it needs to function at its actual capacity. The mountain doesn't exploit your physical weakness. It exploits your cognitive one. And it does it so gradually, so invisibly, that the person making the bad decision has no idea they're making a bad decision. They're doing their best. They're applying everything they know. They're just doing it with a brain that has been quietly compromised by the very environment they chose to enter. This is why the same mistakes happen every season on the same mountains, with better equipped, better trained, more experienced climbers than the season before. The problem was never equipment. The problem was never fitness. The problem is a human brain making decisions in conditions that human brains were never designed to operate in. Before the final section, if you haven't subscribed, do it now. This is the channel that goes into the actual biology and psychology behind what happens at the edge of human survival. Not the highlight reel, the mechanism. Subscribe so you don't miss what's next. Let's finish with what happens when the climber gets down. The frozen tissue looks deceptively stable. White or grey skin, firm to the touch, no feeling. From the outside it looks almost peaceful. No open wound, no blood, no obvious destruction. Climbers who've experienced severe frostbite describe arriving at base camp and genuinely not knowing how bad it was. Their hands looked strange, but they'd been through an extreme experience. Everything felt strange. And then the tissue begins to thaw. And this is when the truth surfaces. As ice crystals melt, the fluid they release floods into tissue that is already swollen from inflammation, already compromised from ischemia, already full of dead and dying cells. The volume increase inside the tissue causes blisters to form, sometimes within hours, sometimes over days. The appearance of those blisters tells doctors a great deal. Clear or lightly colored blisters extending toward the tips of the fingers indicate relatively superficial damage. The blood supply is still reaching the tissue, and the prognosis for saving the digit is reasonable. Dark blisters, blood-filled blisters, blisters that stop short of the fingertip and leave the tip discolored and hard, these indicate deep damage. Ischemia. Tissue that received no blood flow during the critical hours. Tissue that is already dead or dying, regardless of what treatment follows. Surgeons who specialize in cold injury follow a principle that seems counterintuitive to most patients. They wait. They don't amputate immediately. They clean, they dress, they treat aggressively for infection, and they wait. For days, weeks, sometimes months. Because the boundary between dead tissue and living tissue is not immediately visible. What looks dead in the first week sometimes recovers. What looks salvageable sometimes demarcates as necrotic over time. Amputating too early means removing tissue that might have survived. Waiting too long means risking infection spreading from dead tissue into living tissue. It is one of the most difficult clinical judgment calls in surgery, and the patient waits through it, knowing that somewhere in their hand, their fingers, their foot, a line is being drawn. On one side of the line, tissue that will stay. On the other side, tissue that will go. They just don't know yet where the line falls. Climbers who've been through this describe the waiting as worse than the mountain. The mountain was at least moving. The mountain was at least a problem they could engage with. The waiting is just watching your own body decide what you're going to keep. All right, you made it to the end. And that means you understand something now that most people have no idea about. The cold doesn't announce itself. It doesn't escalate in a way that gives you clear warning. It takes what it takes, while you're still standing there convinced that everything is manageable. Here's what I need from you now. First, drop a comment telling me which video you want next. Option 1. What happens to the human brain after 7 days above 8,000 meters? Including why some climbers start seeing things that aren't there. Option 2. Why bodies left on Everest never come down, and what the mountain does to them over years. Option 3. How long it actually takes to die in freezing water, and why everything you think you know about cold water survival is wrong. Type 1, 2, or 3. I pick based on comments. Second, if this video gave you something you didn't have before, hit the like button. It's how YouTube knows this is worth showing.